Imagine you're trying to navigate a brand new, highly complex, smart city, right?
Okay, I'm picturing it.
But the only map you have is like a 2,000-year-old scroll. And this scroll was drawn by someone who, well, they just guessed what the buildings were for based entirely on their shape.
Wow. Yeah, that sounds like a total disaster. You'd be, looking at a high-tech nuclear power plant, but your map labels it I don't know, a cushion storage facility just because the building happens to look soft from the outside.
Exactly. You'd be pressing buttons in the power plant thinking you're just fluffing pillows or something.
Yeah.
And the thing is, when you step into the world of medical terminology, specifically the anatomy of our abdomen, that is essentially what we're doing today.
Yeah, we really are. It's wild.
We are navigating modern high-stakes medicine using a linguistic map drawn by ancient philosophers and, Renaissance surgeons.
It is a literal historical time capsule. I mean, the language we use in hospitals right now today carries all this baggage of, well, centuries of misunderstandings and guesses and completely archaic theories.
Okay, let's unpack this, because the mission for today's deep dive is to explore the medical roots of 3 very specific accessory organs tucked away in your abdomen. We're talking about the pancreas, the spleen, and the gallbladder.
3 of the heavy hitters.
Right. And to do this, we've pulled together this massive stack of sources. We've got historical medical texts dating back to ancient Greece, modern surgical guidelines, current epidemiological research, the works.
And what you're about to discover is that medical terminology isn't just, a dry dictionary you're forced to memorize in med school.
Definitely not. It's a history book. It is filled with bizarre ancient assumptions, totally accidental discoveries, and spoiler alert, even a 17th century murder.
Yes. The murder is maybe my favorite part of this whole history. But what's really fascinating here is that for centuries, these 3 organs were named and defined purely based on what they look like or where they physically sat in the body.
Not what they actually did.
Exactly. Not by what they did at all. The functional definitions of these organs, like the actual science of how they keep you alive day to day, that only really emerged in the last 150 years.
Which is, in the grand scheme of human history, basically yesterday.
Pretty much, yeah. Before that, the study of anatomy, just mapping the shapes, outpaced physiology, which is knowing the functions, by literal millennia.
And for you listening, I mean, this isn't just ancient trivia. We are diving into this because those ancient anatomical blunders and archaic words still directly impact what happens in modern emergency rooms. If you've ever had a stomach ache that a doctor couldn't quite figure out, you are brushing up against this exact history.
You really are.
So let's start with the pancreas, or in medical terminology, the root pancreato. This is an organ that was defined entirely by how boring it looked.
It really was visually uninspiring to early anatomists. I mean, the root pancreato comes from the Greek words pan, meaning all, and creas, meaning flesh. So roughly translated, it just means all flesh.
Which, first of all, sounds like a terrible name for a heavy metal band.
Huh, yeah, it kind of does.
But it's an even worse way to describe a vital organ. Like, why did they go with that?
Well, the name is largely attributed to Greek anatomists like Herophilus. He was working around 300 BCE in Alexandria, and later Rufus of Ephesus around 100 CE. They formally described the pancreas as having this uniform, glandular, boneless appearance.
It's like a blob, basically.
Right, just a massive tissue. There was no rigid cartilage, no bone structure, no major visible nerves running through it. It was literally just flesh.
And because it looks so unremarkable, the great Roman physician Galen made a massive medical error. And this error lasted, 1,500 years?
A staggering error. 1,500 years, yeah. Galen looked at this all-flesh organ. He noted its physical location deep in the abdomen, right behind the stomach and in front of the rigid spine. And he concluded it was essentially the body's bubble wrap.
Bubble wrap. I just can't get over that.
He really believed the pancreas was just a soft, mechanical cushion placed there by nature to protect your delicate blood vessels from rubbing against the hard bones of your vertebrae.
He thought it was packing peanuts. But, okay, think about how that affects a patient back then. Imagine how many mysterious abdominal illnesses went misdiagnosed for over a millennium because doctors genuinely believed the patient had just, bruised their internal bubble wrap.
Oh, absolutely. And because Galen was considered this unquestionable medical authority, that mechanical structural explanation went virtually unchallenged.
Nobody even questioned it.
Nope. It perfectly illustrates how an unchecked assumption from a prestigious source can completely freeze scientific inquiry. Generations of doctors never even bothered to ask what else the pancreas might be doing because, well, Galen already gave him the answer.
So when did we actually figure out what the pancreas does? How did we finally break that streak?
It didn't happen until 1889, and it was a complete accident.
Of course it was.
Right. German physicians Oskar Minkowski and Joseph von Mering were working in Strasbourg, and they were surgically removing the pancreas from a dog. But they weren't looking for blood sugar or diabetes or anything like that. They were running an experiment on fat digestion.
Because by then, scientists knew the pancreas at least dumped some juices into the intestine.
Exactly. So they take the pancreas out just to see what happens to the dog's digestion. But then the lab assistants start noticing something weird happening in the kennels.
So they take the pancreas out, and what happened?
They notice that flies are swarming this one specific dog's urine.
Ooh.
Yeah, pretty gross. But Minkowski, being a rigorous scientist, actually tests the urine and finds it is absolutely loaded with sugar. By removing the pancreas, they had caused the dog to develop severe, fatal diabetes practically overnight.
That is wild. The flies basically pointed them to the discovery.
Yeah, this completely accidental observation proved for the very first time that the pancreas was essential to glucose regulation in the bloodstream. It wasn't just a digestive juice factory, it was controlling metabolism.
Which kicked off the race to find out what exactly the pancreas was secreting into the blood to do that, right?
Yeah, that's the milestone that finally happened in 1921 and 1922. A team at the University of Toronto, Frederick Banting and Charles Best, working in John McLeod's lab, they managed to isolate that substance, which, of course, we now know as insulin.
Wow.
And they used it to save a 14-year-old boy named Leonard Thompson who was actively dying of diabetes. It was such a huge breakthrough that it earned a Nobel Prize the very next year.
But the physical part of the pancreas that makes the insulin is incredibly tiny, isn't it? I read in the notes that a medical student actually found those cells way earlier, but just didn't know what they were.
Yes, Paul Langerhans. In 1869, when he was just 22 years old, he was looking at pancreatic tissue under a newly improved microscope, and he noticed these little clusters of cells that looked totally different from the rest of the tissue, floating like tiny islands.
The islets of Langerhans.
Exactly. We call them the islets of Langerhans today. He documented them, but their endocrine function, meaning the fact that they secrete hormones directly into the blood, that wasn't proposed until decades later.
Let's make sure we're really clear on the mechanism here for everyone listening, because this organ is functionally two completely different organs mashed into one. You have the exocrine gland, which pumps out digestive enzymes through a tube into your intestines. Then you have the endocrine gland, which drops hormones straight into the blood.
Right, two totally different jobs.
It's like, imagine a massive, noisy factory producing acid to break down scrap metal, right? That's the exocrine part, doing the heavy lifting for digestion. But sitting right in the middle of that noisy factory floor is this tiny soundproof glass office making quiet phone calls to the rest of the city to regulate the entire power grid.
That is a fantastic analogy.
Thanks. That's the endocrine part. The islets of Langerhans dictating your entire metabolism. And Galen thought the whole building was just bubble wrap.
It's crazy. And that exocrine factory makes up about 98% of the organ's mass, which is exactly why the tiny 2% in that glass office remained hidden for so long.
So if the pancreas was ignored for centuries as inert bubble wrap, let's move to an organ that suffered the exact opposite fate. The spleen. It wasn't ignored at all, was it? It was actively blamed for humanity's darkest moods.
It really was. Our second root is spleno, which comes from the Greek word splen. You cannot untangle the history of the spleen from humoral theory, which was the dominant medical framework from Hippocrates in the 5th century BCE all the way into the Renaissance.
Okay, humoral theory. This is the idea that human health is just a balancing act of 4 distinct liquids, or humors, right? Blood, phlegm, yellow bile, and black bile. If they're balanced, you're healthy. If one is out of whack, you're sick.
Exactly. And ancient physicians needed to find a physical home for each of these liquids. So they decided the spleen was the seat of black bile, or melena chole in Greek.
Melena chole.
Yeah. They believed that if your spleen produced an excess of this black bile, you developed a sluggish, brooding, profoundly sad temperament.
And this wasn't just some obscure textbook theory. I mean, it fundamentally shaped the English language. The word melancholy literally translates to black bile.
Yes.
When you say someone is feeling melancholy today, you are speaking humoral theory. And if someone gets furiously angry, people still say they are venting their spleen. These are linguistic fossils from when we genuinely thought this organ controlled our negative emotions.
It's fascinating how that stuck around. Also, just a quick note for anyone studying the terminology,
Mm.
you might also see the root lino in the sources.
Oh, right. What's the difference there?
Lino is simply the Latin-derived alternate root for the spleen. But spleno is the dominant form we use in modern clinical terms, like splenomegaly, which just means an abnormally enlarged spleen.
Got it. Okay, so ancient doctors thought it was this mood organ. But as we got into the 20th century, surgeons swung to a completely different extreme, didn't they?
Oh, totally. Because it's not a heart or a lung, meaning you don't immediately drop dead on the table if it's removed. Surgeons started assuming it was this expendable, nice-to-have organ.
They just treated it like a biological luxury. If a patient had abdominal trauma, surgeons would often just remove the spleen freely, assuming the rest of the body would seamlessly compensate.
Right. Until a specific study in 1952 proved that was a terrible idea.
Tell me about that study.
2 American surgeons, Hardin King and Harvey Schumacher, published a landmark paper showing that infants who had their spleens removed weren't just fine. They were actually suffering from dramatically elevated risks of fatal bacterial infections.
Wait, I want to push back on this a little bit. If you can live without it. I mean, people get their spleens removed today and survive. Isn't it technically a vestigial organ?
Yeah.
Like the appendix? What's the harm in taking it out?
I'm so glad you asked that because that is a very common misconception. But the spleen is absolutely not vestigial. It is the largest organ of your lymphatic system. It is a highly active, highly necessary filter.
Okay, so what is it filtering?
It destroys worn-out red blood cells, stores iron, and mounts critical immune responses. More specifically, it houses these specialized immune cells called macrophages, which are essentially the immune system's scavenger cells, and they pull specific encapsulated bacteria straight out of your blood.
Okay, what does encapsulated mean in this context? Why does the spleen specifically have to deal with them?
Encapsulated bacteria, like Streptococcus pneumonia, have this slick outer coating made of polysaccharides. This capsule makes them incredibly slippery. Normal white blood cells circulating in your veins literally can't get a grip on them to destroy them.
So they just slip right past the body's normal defenses.
Exactly. But the spleen's internal architecture is designed like a slow-flowing, dense marshland. It slows the blood down enough that those macrophage scavenger cells can finally corner and consume those slippery encapsulated bacteria. No other organ can fully replicate that specific physical trap.
Oh, wow. So it's not just a generic spam filter for your immune system. It's a very specific physical sieve designed to catch these slick invaders.
That's a great way to look at it.
If you take that sieve away, you can still function. But a catastrophic bug can slip right through the cracks before the rest of the immune system even realizes it's there.
And if we connect this to the bigger clinical picture, that missing sieve leads to a terrifying condition known today as OPSI, overwhelming postsplenectomy infection.
Overwhelming. That doesn't sound good.
It's not.
Right.
Because they lack that marshland to trap the bacteria, a patient without a spleen can go from feeling mildly unwell with a slight fever to going into full septic shock and dying within 24 to 48 hours.
Good Lord.
Yeah, the mortality rate can be staggering. That 1952 discovery changed the standard of care forever. Today, patients who lose their spleens require very specific lifelong vaccines against those encapsulated bacteria, and they are counseled to seek immediate emergency room care at the very first sign of a fever.
Because they just don't have that safety net.
Exactly.
So if removing the spleen in the 1950s taught surgeons that we can't just throw abdominal organs in the trash without severe consequences, you'd think we would be incredibly hesitant to remove other things. But that brings us to an organ that we surgically take out all the time today. The gallbladder.
Which brings us to our third root, cholecysto. This is a combination of 2 Greek words, chol, meaning bile or gall, and kystos, meaning bladder or sac.
Literally the bile sac.
Right. And right away, looking at the terminology, we have to differentiate this from hepato, which is the liver.
Oh, this is a huge trap when learning how the body works. People think the gallbladder makes bile. It doesn't, right? The liver, hepato, makes the bile.
Correct. The gallbladder just stores it, concentrates it, and then squirts it into your small intestine when you eat a fatty meal to help emulsify the fat.
Basically acting like dish soap breaking down grease in a frying pan.
That's the perfect way to visualize it. Now, the gallbladder was known anatomically for a long time, but cholecysto as a clinical concept is really tied to the birth of modern abdominal surgery. For centuries, if you had gallstones, Doctors essentially practiced therapeutic nihilism.
Meaning what? They literally just gave up and decided doing nothing was safer than trying to fix it.
Exactly that. Therapeutic meaning healing, nihilism meaning a belief in nothing. Before antibiotics and modern anesthesia, opening the abdomen was almost certainly a death sentence from infection. So they gave you painkillers and just hoped you passed the stone naturally.
Which I imagine was agonizing.
Truly agonizing. But in 1882, a German surgeon named Karl Langenbuch decides he's had enough. He performs the first deliberate, planned cholecystectomy, removing the gallbladder entirely. And his justification was fascinating. He didn't just want to remove the stones. He argued that the organ itself forms the stones.
Ah, so it was a massive paradigm shift.
It was. And he was right about the mechanism. Gallstones form when the liquid bile sitting in that sac becomes supersaturated with cholesterol, or when the gallbladder doesn't empty properly, leading to bile stasis. The cholesterol crystallizes into solid stones. Langenbuch realized the environment itself was the problem.
So he just takes it out.
Yep.
But the drama around gallbladder surgery didn't stop in the 1800s. Fast forward to the 1980s, and the transition to laparoscopic or minimally invasive surgery, where they just make tiny keyhole incisions instead of slicing you wide open, that was fiercely contested.
It was incredibly controversial. In
Right.
September 1985, a German surgeon named Erich Mu performed the very first laparoscopic gallbladder removal.
And you would think he'd be celebrated as a visionary hero,
Yeah.
right? Saving patients from massive abdominal scars and long recovery times.
You'd think so. But he was met with intense hostility from the German surgical establishment. Traditional surgeons thought putting cameras and long instruments into the belly was dangerous, blind surgery. They essentially shunned him. It wasn't until a French surgeon, Philippe Moret, performed the operation with a video laparoscope in 1987 and heavily publicized it that the laparoscopic revolution really took off.
Which just goes to show that in medical history, dissemination and visibility often dictate who gets remembered, not just who was chronologically first.
Definitely.
But here's where it gets really interesting. We have to talk about the physical plumbing of these organs because it connects the gallbladder directly back to the pancreas we talked about earlier.
Yes, the anatomical wiring here is precarious, to say the least. The main tube that drains those digestive exocrine enzymes out of the pancreas is called the duct of Wirsung, discovered by a German anatomist named Johann Georg Wirsung.
Okay, I have to bring this up because the notes on Wirsung are insane.
Mm-hmm.
He discovers this pancreatic duct in 1642 while dissecting bodies in Padua. The very next year, he is mysteriously assassinated.
Yeah, murdered.
Historians actually speculate he was murdered over a professional rivalry regarding his anatomical discoveries. People were literally killing each other over the plumbing of the pancreas.
It highlights just how unbelievably high the stakes felt during the Renaissance mapping of the human body. Finding a new structure was a literal path to immortality. But anatomically, Wirsung's pancreatic duct is crucial because of where it goes. It merges directly with the bile duct coming down from the gallbladder and the liver.
Right, they join together just before they empty into the small intestine at a shared opening called the ampulla of Vater. Think of the ampulla of Vater like a two-lane highway where the liver's bile lane and the pancreas's enzyme lane merge into a single, narrow toll booth.
And what happens mechanically if a physical object breaks down right at that single toll booth?
Total gridlock. If a solid gallstone escapes the gallbladder and travels down the tube, it can get lodged right at the ampulla of Vater. And because it's past the merge point, it backs up traffic into both the bile duct and the pancreatic duct simultaneously.
Which creates a condition called gallstone pancreatitis. The gallbladder problem triggers a massive, life-threatening pancreatic emergency.
It's terrifying when you look at the mechanism. You've got those harsh digestive enzymes, the acid from the factory floor backing up into the pancreas itself. The organ essentially starts digesting its own tissue.
It's a surgical emergency. And building on your toll booth analogy, that same physical traffic jam is precisely what causes another clinical term we see often, incter-O, which means jaundice.
Oh, jaundice, right.
When bile backs up, whether it's from a gallstone blocking the toll booth, a tumor pressing on the duct, or liver disease, the bilirubin in the bile spills over into the bloodstream, turning the patient's skin and eyes distinctly yellow. It ties this entire abdominal region together through a shared, very visible clinical sign.
Which perfectly transitions us into why this all matters to a patient walking into a clinic today. Because this anatomical traffic jam isn't just a textbook curiosity. Misunderstanding these terms and relying on outdated mental maps leads to very real, very dangerous medical errors.
It really does. Let's look at the classic 4Fs mnemonic for diagnosing gallstones. For generations, medical students were taught that the typical gallstone patient fits 4 criteria: female, 40, fat, and fertile.
Wait, I hear that and think, well, isn't a mnemonic like that incredibly helpful for a stressed out, overworked medical student? Why get rid of a memory tool that helps them quickly identify a common pattern?
Because that tool often acts as a blinder. Modern epidemiology recognizes the 4Fs as a massive oversimplification. I mean, yes, those hormonal and weight factors matter, but gallstones are also strongly linked to rapid weight loss and specific ethnic backgrounds. Indigenous American and Northern European populations have notably high rates of stone formation.
So it's way more complex than just 4Fs.
Much more. If a clinician relies too heavily on that catchy mnemonic, they might completely dismiss the severe abdominal pain of a 25-year-old male athlete sitting right in front of them simply because he doesn't fit the rhyme.
That makes a lot of sense. The memory trick actually stops you from seeing the unique patient in the room. And this raises a similar issue with acute pancreatitis, right? The notes show a huge public misconception about what causes it.
There is a massive diagnostic bias here, yeah. If you ask the general public, and frankly many busy clinicians, what causes a pancreas to suddenly inflame, the default assumption is almost always heavy alcohol use.
Because that's what decades of public health messaging and medical television shows have hammered into our heads. Pancreatitis equals alcohol.
Exactly. But epidemiological studies show that gallstones cause a comparable, and in many demographics, a much larger share of acute pancreatitis cases than alcohol does. Together, they account for the vast majority, but the bias persists.
And assuming it's just an alcohol disease has tragic, real-world consequences. I mean, if a clinician assumes a patient's pancreatitis is simply due to their drinking history, how does that hurt the patient?
It changes the immediate workflow. The doctor might delay the ultrasound or the abdominal imaging needed to find a physical gallstone.
Oh, because they think they already know the cause.
Right. And a gallstone-driven case can be treated definitively, often by going in and clearing the duct or removing the gallbladder. Missing that physical blockage because of an ingrained bias about alcohol prolongs the patient's suffering and drastically increases the risk that the pancreas will suffer irreversible tissue death.
It also comes back to just getting the medical words right, doesn't it? Because they sound so similar. Students constantly mix up chole, which is the general term for bile or gall, with cholecysto, which specifically refers to the sac holding it.
That leads to the most common student error, confusing cholecystitis with cholangitis.
These sound like the exact same word. But cholecystitis is inflammation of the gallbladder itself. Cholangitis is inflammation of the bile ducts, the highway leading away from it.
Physically, they're different structures, and confusing them changes the severity of the diagnosis and the entire surgical treatment plan. The terminology demands precision because the underlying physiology demands precision. You can't just call it all bubble wrap or black bile anymore. The stakes are too high.
Which brings us full circle. Why does this deep dive matter to you, the listener, as you go about your day? Well, disease is tied to these 3 roots. Pancreato, spleno, and cholecysto are not historical curiosities tucked away in a museum. They are driving massive numbers of gastrointestinal hospital admissions every single day.
Millions of people are managing their diabetes with insulin therapy right now, which is a daily reality that traces a direct, unbroken line back to that accidental observation of a dog in Strasbourg in 1889.
It's amazing to think about.
And laparoscopic cholecystectomy, despite its rocky start, remains one of the most common surgeries performed globally today.
And if you've ever had infectious mononucleosis and the doctor told you to absolutely avoid playing contact sports for a month, that is directly tied to this anatomy.
Yes, the spleen.
The virus physically enlarges your spleen, stretching that slow-flowing marshland we talked about and making the outer capsule incredibly fragile. The doctor is trying to prevent a blunt force impact from causing a splenic rupture, which is a massive internal bleeding emergency.
The ancient world may not have understood the cellular physiology of these organs, but they certainly left their mark on how we conceptualize and talk about them.
Which leaves us with a final thought for you to ponder. We've seen how the word melancholy fossilized the completely obsolete ancient science of black bile into our everyday speech. When you use that word, you are essentially navigating emotional health using a 2,000-year-old map.
Right.
So, what common medical or psychological terms are we using with total confidence right now that future generations will look back on as embarrassing linguistic fossils of our own scientific ignorance?
It really makes you wonder what parts of our current medical map are still just guessing at the purpose of the buildings based on their shape.